Hello everyone, happy afternoon or very good afternoon. Am I audible and visible, everyone? All right, that's great. So I hope and I believe all of you are doing well, guys. So today is 10th of January and you have your exam on 12th of January, that's day after tomorrow. I can totally understand, how anxious you might be and how stressed you might be. But what you can do is just imagine the worst case scenario, what can happen and what can go wrong. And at the end, if you realize it's just one exam and one exam result, and it is not like the life or that situation that you have, right? So do not stress out yourself too much for one exam. I know it's very important exam, right? But that does not mean that this is the last chance as well, right? So thinking this, you can calm down yourself, but at the same time also remember that if you are feeling bad ki, why did I waste my time before, why did I not read before or anything, just remember, so this is for everyone here, remember that a last minute goal or a last ball can change the entire game. So try up to till the last minute and anything can be possible, right? So, jab tak it is your last question on your computer screen in the exam hall, the last minute of your exam, tab tak hame haar nahi manni hai, right? So that's what the learning lesson is. The game can change anytime provided you are there on the ground playing the game. अगर गेम छोड़ के चले जाओगे ग्राउंड से ही तो यू आर प्रीटी श्योर दैट यू आर नॉट गोइंग टू विन द गेम, राइट? यू आर डेफिनेटली गोइंग टू लूज द गेम. But if you are there, staying there on the ground and telling yourself कि last ball तक भी game change हो सकता है, and you do not get scared by the few initial difficult questions, right? So anytime the game can change. Okay, it's absolutely fine, Dr. Phoenix, right? What will it cost is just another 6 months. Okay, but it is really not worth it to stress yourself out and give so much of anxiety and catecholamine release in your body. It's absolutely fine. क्या ही फर्क पड़ने वाला है, कि 6 months late हुआ या whatever, right? I'm praying that each one of you clear the exam this time itself and you move on to your next milestone in your journey. But at the end, suppose God forbid if things don't go the way that we had expected, it's just another 6 months. 1 year down the line, 2 years down the line, or few years down the line, even you would not remember, nobody else would remember, and no patient is going to ask you, when did you crack the exam? So it's absolutely fine. Okay. मनीष, बिल्कुल भी पढ़ा नहीं जा रहा है. See, whoever is not able to study or focus, first of all, leave everything aside and just close your eyes and try to meditate, right? If you're not able to get sleep as well, you need some relaxation. Like I always suggest, I do it myself as well. Please do Yog Nidra. Okay, it's available on YouTube in Hindi, in English, right? So just practice that. It's a 15 to 20 minutes practice, but you would definitely feel a much more relaxed once you do that. Okay, try practicing that and just at least go through the PYQs quickly. Okay, question answer at least utna to kar lo. Do not solve the questions. Okay, in detail में पूरे question solve मत करना, right? Just look at the question and the answer. और जहाँ पे भी लग रहा है कि ये topic मुझे याद नहीं आ रहा है, वो वाला part revise कर लो. Okay, so please do not feel frightened or scared. You all are going to do very, very well in the exam. Okay. All right, my pleasure, Dr. Pragati and everybody here. Any suggestions, Dr. Yashwant, for ophthalmology guaranteed top 10 topics? है ना, सेशन है, क्यों नहीं है? Right? If I start with motivation does not mean कि सेशन नहीं है. PDF मैंने already share किया हुआ है ना? देखो, ophthalmology में guaranteed top 10 topics which are the most important. What comes to my mind is the actions of extraocular muscles, very, very important. Then you have the various fundus images and diabetic retinopathy, hypertensive retinopathy, which is very, very important. One question on glaucoma, right? That's generally there. Then you have questions on cataract, uski surgery, uske complications, wo sab jo hain, that's again important area that you should focus on, right? Then the refractive errors, ठीक है? So these are what come to my mind. Okay, yeah. Apologies, I could not take a session live yesterday because, like I mentioned in the Telegram group, my daughter Kyra was not keeping well, and that's why we could not do a session yesterday. We have two sessions today. This is the session 3. We will have part 4. The final session that we have is today evening 7:30 p.m. We will have the part 4, and tomorrow we will meet live again for the final exam hall strategy, and you to calm down your nerves. So we will have the final YouTube live strategy. We will not discuss the topics, but just what are the tiny things that you should take care of when you are there in the exam hall. That's what we are going to talk about. Okay. Pharmacology, Harika, remember your exam favorite is anticoagulants, antiplatelets is an area which is very, very important, right? Of course. Pharmacology, I can tell you that do pharmacology Sureshot from the Radsynapse app. If you have not done that, it's absolutely fine. But if you have done it, revise it very well. Majority of the topics have been covered. Okay? Chalo. All right. So let's start discussing the today's topics. Like many of you had requested ECG revise karna hai last minute wala. So quickly let's revise the ECGs first, then few more images. So today's session 3 is predominantly image based. Okay, so tell me that what do you think is going to be the answer for this one? Okay, in the today's session, that's the last session, session 4, I'll try to cover a lot of one-liners based on your PYQs, right? So it's going to be like a rapid fire revision of the PYQs in the form of one-liners. That's what I'm planning. Okay, very good. What is the treatment of choice? Very good. All of you have got this right. It's going to be cardioversion. Why cardioversion? Because the patient is unstable, right? Always keep in mind that when the patient is unstable, right? When the patient is unstable, you do not waste time and you directly go for cardioversion. What is the diagnosis here? This is PSVT. Absolutely right. The image here is showing PSVT. Why is it PSVT? Remember, supraventricular tachycardias, they have narrow QRS. That's how you differentiate supraventricular from ventricular tachycardias. Okay. When you see a narrow QRS complex and you have, how is the rhythm here? The rhythm is a regular rhythm that you are seeing here, right? It's a regular rhythm. There's tachycardia and you see narrow QRS complex. The P wave is getting hidden here in the QRS complex itself. Regular rhythm, absent E wave, it's going to be basically your cardioversion. Okay? Is this clear with everyone? This is very favorite question for the exam. PSVT ka ECG, narrow QRS, regular rhythm, very, very important. If the patient is stable, then you would do vagal maneuver, and if it is not responding, then you go for adenosine. And also remember, if adenosine also is not working, then what is the next drug that you give? This is one of the NICT PYQs. पहले आप करते हो वेगल मैन्यूवर्स, राइट? देन आप करते हो एडिनोसिन आईवी देते हैं. अगर एडिनोसिन भी काम नहीं कर रहा है तो yes, if adenosine also is not working, then what is the next drug that you give? So look at the flow chart here. PSVT, if the patient is unstable, you directly go for cardioversion. Unstable patient is basically blood pressure less than 90/60. Okay, blood pressure less than 90/60 is what is unstable. Okay. अब्लेशन कहाँ पे आता है रश्मि? डू नॉट गेट कंफ्यूज. अब्लेशन मतलब सोचो हम किसका अब्लेशन करते हैं? एक्सेसरी पाथवे का अब्लेशन करते हैं. वो कहाँ होता है? वो होता है WPW सिंड्रोम में, जब बंडल ऑफ केंट है, राइट? सो रिमेंबर, इफ द पेशेंट इज स्टेबल, you go for Valsalva's or carotid massage. If it is still persistent, then you go for adenosine. And if there is still after adenosine, then you give CCBs. Calcium channel blocker is the next drug after adenosine that you give. Okay, so the next drug that you give here is calcium channel blocker, right? And remember, for adenosine, what side effect do you remember? What side effect can adenosine have? Remember, it can cause bronchospasm. Okay, bronchospasm is what it can cause. So it is contraindicated in asthmatics. Asthma wale patients mein aap nahi doge. Okay, now look at the image here. So this is a narrow QRS complex. So this is going to be PSVT. And look at the complexes here. How are the complexes here? These are broad QRS complexes. This is going to be ventricular tachycardia. Okay, keep this image in mind. Ventricular tachycardia is the broad QRS complex. Supraventricular is narrow QRS complex. Whenever you are given an ECG image like this, try to look at the lower, the long lead 2 at the bottom. You can see that there are broad QRS complexes which are regular. This is going to be ventricular tachycardia. Okay, this is basically ventricular tachycardia. Is this clear with everyone? Right? Is this clear with everyone? Right. Okay. Going on to the next one. This is a very favorite ECG image. I've tried to put the most important, like, the frequently asked ECG images. What are you seeing here? Look at the ECG image here. Waxing, waning जैसा है, waxing, waning जैसा है. Basically, जो twisted ribbon होती है, you have a ribbon and you try to twist it. It goes like this, right? So when you have this appearance here, this is going to be twisted ribbon is torsidus d pointus. Torsidus d pointus. Remember all the hypoelectrolytes, hypokalemia, hypocalcemia, hypomagnesemia, right? Hypokalemia, calcemia, magnesemia basically will precipitate torsidus d pointus. What is the drug of choice here? Very, very important question. What is the drug of choice here? The drug of choice here is IV magnesium sulfate. Okay, we give magnesium sulfate here in torsidus d pointus, right? It is also called polymorphic ventricular tachycardia. Okay, and what predisposes to torsidus d pointus? It's going to be long QT. Long QT predisposes to torsidus d pointus. Okay, torsidus d pointus. Long QT predisposes to torsidus d pointus. Okay. Right, and which antiarrhythmic drugs? Class 1 and class 1A and class 3. Okay, they precipitate torsidus d pointus. Remember torsidus T for 3. Class 3 drugs and class 1A drugs precipitate. So amiodarone is included in class 3, but remember out of class 3, amiodarone has the least chance of causing torsidus d pointus. Okay. Alright, look at this one. What are you seeing here? A prominent U wave. Very, very important question. Where do you see a U wave? In which electrolyte abnormality? Where do you see a U wave? In which electrolyte abnormality do you see a U wave? So, easy trick to remember is U for under. Okay, UK. Remember U for UK, that is under kalemia, that is hypokalemia. Okay. So, what causes U wave is hypokalemia. Always remember that UK under kalemia is U wave. Okay, U wave. And what do you see here? What do you see in this ECG here? What electrolyte abnormality? Look at the T waves here. Look at the T waves here. What are the T waves looking like? Tall, tented T waves. Okay. Remember, T is the repolarization, and the repolarization is because of potassium. So, increased T basically means increased potassium. That's going to be hyperkalemia. Okay, hyperkalemia. And when this becomes severe hyperkalemia, you get sine wave pattern. Remember, sine wave pattern is seen in sign for severe increased potassium. Okay, severe increased potassium more than 8, that is when you get sine wave pattern. What do you use for treatment of hyperkalemia? If there are ECG changes present like this, the first thing is stabilize the heart. So, what do you give is calcium gluconate is what do you give to stabilize the heart first. It does not decrease the potassium levels, but it stabilizes the heart, reducing arrhythmias. Okay. Right. Then you have insulin, salbutamol, potassium binding resins that are given. Okay. So remember, this is sine wave pattern. This is hyperkalemia and you have tall tented T waves. Very, very important. Going to next one, atrial fibrillation and atrial flutter. Fibrillation means the atrium is not contracting. The P wave is going to be absent, and very, very important. It's an irregular rhythm. Patient starts feeling the palpitations, then there is syncope, right? And there is irregular rhythm. You do not see a baseline, right? Baseline ही अपने देखते irregular rhythm है. This is atrial fibrillation. Okay, this is atrial fibrillation. What do you do here? What do you do in atrial fibrillation? Rate control, rhythm control, and you have anticoagulant also, which is given. Always remember, for atrial fibrillation, what anticoagulant do you use to prevent the stroke that can occur because of atrial fibrillation? Yes? Yes. What drugs do you give as anticoagulants? Remember, you have two options, that is the newer oral anticoagulants or the older one, which is warfarin. Right? Generally, what do you prefer is the Novax, newer oral anticoagulants. Okay. When do you give warfarin? Remember important points. Warfarin, WA is VA. Anything which is valvular related. If the atrial fibrillation is because of a valvular pathology like mitral stenosis, rheumatic heart disease, or it's a prosthetic mitral valve. If it is related to a valve, then you give warfarin. Otherwise, you give Novax. Which are the Novax? Which is the oral direct thrombin inhibitor? Which is the oral direct thrombin inhibitor? Very, very important question. Which is the oral direct thrombin inhibitor? Oral, which is given directly oral, that is dabigatran. Remember, dabigatran, TR is thrombin, AN is antagonist, and it is given direct oral. Plus, which are the other drugs given orally? The direct factor 10A inhibitors like rivaroxaban, apixaban, right? XA banning drugs, the factor 10A banning drugs which are acting on factor 10, right? So, you have factor 10A inhibitors and oral direct thrombin inhibitor, that is dabigatran, which are given, okay, to prevent the stroke. What score do you use here? Chad's-Vasc score, which tells you that what is the risk of stroke and whether we need to give anticoagulant or no. Okay, and you give for rate control, rhythm control, and then you have cardioversion, chemical cardioversion, which is the drugs basically that you give, or you give a shock wala. ठीक है? And remember that rate control में हम कौन से drugs use करते हैं atrial fibrillation में? जब रेट कंट्रोल करना है फ्रॉम द एट्रियम टू द वेंट्रिकल, बेसिकली यू आर गिविंग AV ब्लॉकिंग ड्रग्स, ABCD. AV blocking drugs are beta blockers, calcium channel blockers, and digoxin. Will you use lignocaine here? No, lignocaine is not used because lignocaine only acts on the ventricle, not on the atrium. It does not act supraventricular, right? Lignocaine acts better on ischemic myocardium, so it is given MI वाले arrhythmias में, acute arrhythmias में. ठीक है? Is this clear with everyone? Yes, for rhythm control, you do give ibutilide. Right? Rhythm control के लिए you have ibutilide, amiodarone, which is given. Okay? Right. And look at atrial flutter is comparatively more regular rhythm, and you have the sawtooth pattern that you have in atrial flutter. Okay? Sawtooth pattern in atrial flutter. Going to next one, multifocal atrial tachycardia. The most important clue in the question here will be a patient who's a COPD patient, asthma patient, COPD patient. ये history रहेगी, and you are given this multifocal atrial tachycardia. Atrium से आ रहा है, मतलब क्या abnormal होगा यहाँ पे? P wave multiple morphologies की होगी. Okay, look at the various P waves morphologies that are shown here. At least 3 different P wave morphologies. What you have here in multifocal atrial tachycardia, history of COPD is very important here. Okay, clear with everyone? Coming to pulmonary embolism, the most common ECG finding that you have with pulmonary embolism is sinus tachycardia, right? There's tachycardia that you see. And the most specific sign is this S1Q3T3 pattern. Okay, in lead 1, the S is prominent, then you have Q and T inversion basically present in the lead 3. So, S1Q3T3 pattern, that is Magdalen-White sign, is what is seen in pulmonary embolism. Okay, S1Q3T3 pattern. Coming to next one, the degrees of AV block, right? When the AV is getting blocked, so basically the time required for atrium to ventricle conduction increases. So you will have this will be presented as long PR. Prolonged PR is the first thing that you would see, right? More than 0.18. Okay? Palas and Hampton, Taranum, remember those are the chest X-ray signs of pulmonary embolism. Okay, those are the X-ray signs. So prolonged PR is what you see. How do you calculate PR? From beginning of P to beginning of QRS. ठीक है, beginning से beginning basically ये है आपका PR interval. The PR interval is prolonged in first degree. Okay, in first degree only there is increased PR. In second degree AV block, remember second is do मतलब dropped. ठीक है, dropped beat is going to be present. What do you see here? R दिख रहा है यहाँ पे, फिर यहाँ पे basically drop हो रहा है. ठीक है, P followed by QRS, P followed by QRS, and after a P there's a drop which is present here. Whenever a drop is present, it's a second degree AV block. Okay, so in second degree, basically you have Mobitz block. Okay, Mobitz, remember Mobitz is bi. That means it's a second degree block. You have Mobitz type 1 and you have Mobitz type 2. 1, remember Mobitz type 1. 1 is a Wenckebach phenomenon. So where do you see Wenckebach phenomenon? In 1. 1 is Wenckebach. Okay. So the PR interval here increases progressively and finally there's a drop. Okay. पहले इतना PR है, फिर इतना PR है, फिर इतना PR है और फिर drop आ गया. While in Mobitz type 2, it's a constant PR prolonged plus there's a drop present. PR prolonged, PR prolonged, PR prolonged. After a P, there's a drop present. So what is the difference between first degree and Mobitz type 2 is, in first degree, there is no drop beat. In second degree Mobitz type 2, there's a drop beat also present. So if a drop beat is present, then you will call it second degree. Third degree complete heart block means atrium अपना कर रहा है, ventricle अपना कर रहा है, the PP is constant, the RR is constant. But they are independent of each other. P can come before QRS, after QRS, merging with QRS anywhere, right? So the RR is constant, the PP is constant and they are independent of each other. The P is coming after QRS, the P is coming before QRS. ये दोनों अपने हिसाब से चल रहे हैं third degree block में. Okay, the RR is constant. Okay, it's regular in third degree. Okay, that is what you should remember here. Is this clear with everyone? Yes. Okay, so this is about the AV blocking, the AV block that you have here. Going to next one, coming to some important waves that you have, extra waves in ECG. This is the Osborne wave. जहाँ QRS खत्म हो रहा है वहाँ पे एक और wave आ रही है. So at the J point, Osborne O, remember, is seen in hypothermia. Okay, it is seen in hypothermia. What wave are you seeing here? This was asked in the recent NEET PG 24 exam or INICT exam, one of the recent exam. Okay, so when you see something like this after the QRS, okay, say E जैसा कुछ दिख रहा है, this is called as epsilon wave. And where do you see epsilon wave? Remember epsilon, ear epsilon is seen in ARVD. Arrhythmogenic right ventricular dysplasia, where the right ventricle muscle is replaced by fibrofatty tissue, becoming arrhythmogenic. So remember, epsilon wave is ear, it is seen in ARVD. Okay, it is seen in ARVD. Look at this, look at the QRS going like a sloping one, like a slanting line, right? This is basically called as delta wave. Delta wave is seen in WPW syndrome, where you have accessory bundle of Kent, which is faster conducting as compared to AV node. So how is the PR here? PR is going to be short क्योंकि ये faster conducting है. How is the QRS going to be here? QRS you can see is going to be broader because it's an abnormal pathway. It's going to be broader. Okay, the PR is going to be short, the QRS is going to be broad, and it's going to have this delta wave. Remember that here in WPW you do not give drugs which cause AV block. You have AV node, you have bundle of Kent which are competing to pass the signal. If you block the AV, so this is getting the dominance, right? So this is winning. You do not want this to happen. So do not give AV blocking drugs here, like digoxin is not given, okay? And yes, what do you give as procainamide? Correct. Right, is this clear with everyone? And what is going to be the definitive treatment for WPW syndrome? The bundle of Kent is the problem. तो वो bundle of Kent को उड़ा दो, basically उसका क्या कर दो? Ablation कर दो, ठीक है? Ablation of the bundle of Kent is what is the definitive treatment here, right? Clear with everyone? Coming to MI, how do you localize its anterior wall, lateral wall, inferior wall, right? So how do you keep the leads as V1, V2, V3, V4, V5, V6, right? That's how it goes. So if this is the heart here, so basically ऐसे start होगा V1, V2, V3, V4, V5, V6. So V1, V2 जो है ये है enteroseptal, ठीक है? V3, V4 apical में आएगा, V5, V6 lateral में आएगा. Now in the inferior MI, remember inferior of the body is the foot. So AVF, which is towards the foot, 2, 3 AVF is inferior wall MI. AVL, L is for lateral. Okay, AVL, L is for lateral. Okay, is this clear with everyone? In the posterior wall MI, you would see reciprocal changes in the anterior wall leads. Right, V1, V2 will show ST depression in posterior wall MI. Because if there is V1, V2 depression, you can think of posterior wall MI. Clear with everyone? Okay, so look at this one and tell me that what wall MI are you seeing here? What wall MI are you seeing here? Very good. Correct, Sharavali. I'll come to that. So look at this. This is 2, 3 AVF. Okay, 2, 3 AVF like जैसे foot वाला shape होता है. ये वाली जो leads है यहाँ पे, इसमें you can see the ST elevation like a tombstone appearance. Okay, tombstone appearance, Pardee sign, that is what it is called. It is inferior wall MI, which is because of right coronary artery. Inferior wall MI, right coronary artery, supplying the SA node and the AV node also. So when that gets affected, remember this MI will have bradycardia, it will have hypotension that's going to be present, but there's going to be bradycardia here instead of tachycardia. Okay? And in the treatment, you give your IV fluids, you give atropine. ठीक है, जो पैरासिम्पैथेटिक सिस्टम ओवर एक्टिवेट हो रहा है उसको ब्लॉक करने के लिए आप एट्रोपिन दे रहे हो और आईवी फ्लूइड्स दे रहे हो. रिमेंबर, वेरी वेरी इंपॉर्टेंट. ओके, वेरी वेरी इंपॉर्टेंट. Right, and so inferior wall MI is because of generally the right coronary artery which also supplies the posterior wall, so generally they come together. Okay, all right. So this is your few assessment questions here. Tell me, what do you think will be the answer to the first one? 60-year-old woman taking furosemide is noted to have U wave. What is going to be the answer here? U for UK, underkalemia. So that's going to be hypokalemia. Okay, the answer is going to be A. Is this clear with everyone? Then you have man presents with fever and chest pain, angina hai. There is concave elevation of the ST segments in leads 2, V5 and V6. What is the answer to this one? What do you think will be answer to this one? Yes. Okay, Shri, I'll come to that. Okay, is this a lateral wall MI? अगर lateral होता तो ABL में आना चाहिए था, lead 2 में आ रहा है, V5, V6 में आ रहा है, ये तो कोई territory में fit ही नहीं हो रहा है. Brugada is going to be lead V1 and V2, coved ST segment elevation. Very good, Sheravali, Tarannum, correct. This is pericarditis, guys. Look at the question. This is where we make silly mistakes. It is concave elevation of the ST segment. Remember, ST segment elevation, when it is there, you need to think of two possibilities. One is MI, one is pericarditis. At least itna to aapko sochna hai, ye do possibilities. MI is a sad event, right? And pericarditis is a better event. So remember that MI sad face हम कैसे बनाते हैं? ऐसे बनाते हैं. It is convex elevation. Pericarditis कैसा है? Better event है. It's a smiling one. It's a concave elevation. So concave elevation, not confining to any territory. This is going to be pericarditis. Okay, this is not MI. This is pericarditis. Is this clear with everyone? ठीक है? Yes. Going to next one. S wave in lead 1, Q wave in lead 3 and T wave inverted in lead 3. So this is S1, Q3, T3. What is this going to be? This is going to be pulmonary embolism. Okay, this is going to be pulmonary embolism. Next question. Tell me, what do you think will be the answer to the question number 4? Undergone thyroidectomy, has ECG with QT interval of 0.5 seconds. What is this? थायराइड के साथ हमेशा याद रखना कि थायराइड के बाजू में पैराथायराइड होता है, एज द टर्म सेज. सो पैराथायराइड भी निकल गया तो कैल्शियम कम हो जाएगा. सो बेसिकली दे आर पॉइंटिंग टुवर्ड्स हाइपोकैल्सीमिया. right? And what does hypocalcemia do in the ECG? Calcium is required for heart contraction. No calcium, everything is becoming slow. So prolonged time, the QT increases. There is prolonged QT that you are seeing here. Okay, so 0.4 से ज़्यादा है यहाँ पे 0.5 है. It's a prolonged QT. Okay, long QT, hypocalcemia causes long QT. Next one, interesting question. A woman who presents with hoarseness of voice, pulse rate 44 है, ECG में भी bradycardia है, and there is reduced amplitude of PQRS and T waves in all the leads. What is this? Yes, what is this going to be? And you have the options here right in front of you. So look at bradycardia, look at hoarseness of voice, look at the decreased amplitude. No. Very good. This is hypothyroidism. So basically myxedema that is coming here. This is hypothyroid ke features. Remember hypothyroid, there's bradycardia, right? And there is basically, what are you seeing here is pericardial effusion is what you see with hypothyroidism. Pericardial effusion. And because of this pericardial effusion, there is going to be decreased amplitude. Okay, decreased amplitude of the waves that you are going to see because of pericardial effusion. Is this clear with everyone? Right? So that was about the quick review of ECGs, guys. Remember PSVT, torsidus depointus, atrial fibrillation, U wave, tall tented T wave. This is what is generally asked. Yeah, this is something that we missed here. What are you seeing here? What is this ECG showing? Q, right? You have Q, R, and then you have this ST, which should have been isoelectric flat line. So what is this image showing here? This is showing ST depression. Okay, remember this is ST depression. So remember ST depression, digitalis is what shows ST depression rather than ST elevation. Digitalis का आपको कैसे याद करना है? Remember PR. PR for PR, it is prolonged. QT becomes choti, that is short QT because it increases calcium. ST becomes depressed, depressed ST rather than ST elevation. So you have this hockey stick sign, tick mark sign, or like this mustache wala sign, which is Salvador Dali mustache sign. Okay, PR prolonged, ST depressed, QT choti, and T becomes ulti, that is inverted T wave is also what it can show. The most common arrhythmia that it can also lead to arrhythmia, right? So remember, it can lead to ventricular bigeminy is the most common arrhythmia that you see with digoxin. Okay, ventricular bigeminy. Okay, clear with everyone? Chale aage, give me a quick thumbs up if this quick review of ECG is done. Okay, now going to some microbiology important images which are like very important for your exam. The first one that you see here, this is the slabbed cheek appearance, right? Slabbed cheek appearance, very important, which is seen with erythema infectiosum. Okay, erythema infectiosum, which shows slabbed cheek appearance, which is seen with parvovirus. Remember, this is called as fifth disease. Okay, this is called as fifth disease. Tell me, parvovirus. Is it a DNA virus, RNA virus, single-stranded, double-stranded? What is it? Yes, Disha, thank you for reminding. Remember, for NSTEMI, that is non-ST elevation MI, you do not do basically thrombolysis. What do you do there is, you give anticoagulants, you give antiplatelet drugs. Heparin is what you give for NSTEMI. Always remember that. Very good. Absolutely right. Remember, parvo DNA virus है, parvo single-stranded DNA है. Right? So remember, single-stranded DNA virus is a parvovirus. Parvo single-stranded DNA virus है. Okay? And double-stranded RNA is your rotavirus. So this is the erythema infectiosum, parvovirus. What is the other thing that you always remember for parvovirus apart from this? This is a cause of non-immune hydrops fetalis. Okay, it leads to the aplastic crisis, right? It leads to aplastic crisis. It can lead to anemia and it can lead to hydrops fetalis. Okay, going to next one. Identify this virus here. What virus is this one here? Very good. This is Ebola virus. Okay, remember E के बाद आता है F. It is filamentous virus is Ebola virus. Okay, this filamentous virus here is Ebola virus. Very, very important, right? You should always remember this. This is Ebola virus, which is filamentous shape Ebola virus. What virus is shown here? Right, if the examiner is like me and forgets to remove this one here, right, so you can see that this is Nipah virus. So always remember, whenever you have image based questions, aise pehle bhi hua hai, there might be some trick hidden in the image itself, right? So provided the image is good or your vision is good, you should always look for this tricks here. This is Nipah virus, has been asked in recent NEET PG exam. Nipah virus, absolutely, right? So you guys remember the mnemonic, right? The met synapses here. Nipah, remember Ni for Nikita, right? Nikita loves eating fruits. Okay, so remember fruit bat is what will be shown here. Okay, fruit bat will be shown here. Plus you have Nipah ka P for pig also will be shown here. So recent NEET PG में fruit bat वाला एक image था. So remember fruit bat is Nipah. Okay, so fruit bat or pig dikh raha hai, that's going to be Nipah virus. Okay, that's going to be Nipah virus. Correct. Going to next one. This is another area where you definitely get one question in the exam, and that's based on vectors. Okay, what is the first one that you are seeing here? The mosquito which is having this striated appearance, white, black, white, black, white, black, like a tiger. So which is the tiger mosquito? Aedes. Aedes is the tiger mosquito. Okay. Never ever forget, what does Aedes transmit? Yes, absolutely, Nirday, correct. So remember this mnemonic, Aedes. That is how you write Aedes. Yellow fever, dengue, chikungunya, zika. कभी मत भूलना कि Aedes क्या क्या transmit करता है. This is very, very important for your exam. Aedes is Aedes, Y-D-E-C-Z. Yellow fever, dengue, chikungunya and zika. All of these are Aedes transmitted. Okay. Next one, where you have the spotted wing sitting at an angle. Angle pe baitha hai. AN is Anopheles mosquito, has spotted wings. Okay. Anopheles, female Anopheles mosquito is what is the vector for malaria. Okay. This is for malaria, female Anopheles. Where you have this hairy vector, ऐसे बहुत सारे hair हैं, like the kala hair, it's kala azar causing vector. Kala hair, kala azar, this is sand fly. Okay, this is sand fly which causes kala azar, leishmaniasis. Okay, remember that's leishmaniasis. Always remember, for leishmania, the patient is a patient from Bihar, UP, Rajasthan, right? And it can affect the spleen, the liver, it can cause pancytopenia, it can cause skin lesions as well, right? Post kala azar, dermal leishmaniasis, where you give miltefosine. Okay, what is the drug of choice for kala azar, visceral leishmaniasis? You have liposomal amphotericin B, which is given here. For dermal leishmaniasis, you give miltefosine. Okay, phlebotomous, right? So this is basically sandfly phlebotomous. Next one, what is this one here? Which has a hard part in the front, the thorax and the abdomen can be differentiated. This is the hard tick, right? This is hard tick. I hope all of you remember the rhyme that we sing on the Congo, right? We sing the rhyme on the Congo and the rhyme is for hard tick is, baby tu hai hard, tick, tick, tick. Hard like a rock, tick, 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 right? And the baby says, kya faltu lagaya hai, right? So all of you remember the mnemonic. Rhyme is the Lyme disease. Congo is the Congo hemorrhagic fever wala jo hai. Then you have baby, that is babesiosis. Baby tu hai hard. Tu is tularemia. Baby tu hai hard, tick, tick, tick. Hard like a rock. Rocky Mountain, spotted fever. And the baby is kya faltu, that is KFT. Okay, all of these are basically hard tick transmitted. Okay, baby tu hai hard, correct. And what is this one here? This is the mite. Okay, remember trombiculid mite. Trombiculid mite is for T for T, that is Susugamushi. Rickettsia wala Susugamushi. What does that Susugamushi cause? S for scrub typhus. Okay, that is for scrub typhus. So trombiculate Susugamushi, and that's going to be scrub typhus. Your rickettsia is also important, right? We have discussed all of that in the Sureshot microbiology. Okay. Going to this one, what is this? This one here, where you see this broad-based budding. BBB, broad-based budding is seen in B, that is blastomycosis. Remember, B is like 8. It gives you this figure of 8 appearance, blastomycosis. Okay, blastomycosis. What findings do you get in blastomycosis? Which organs are affected? Remember, blastomycosis, it blasts the lung and skin. Okay, it affects the lung and it causes skin lesions as well. Okay, skin as well. This one, which is like the pilot wheel appearance. जो pilot का wheel होता है, P for P, pilot wheel is paracoccidioidomycosis. Paracoccidioidomycosis, P for P, is this pilot wheel, Mickey Mouse appearance is what you see here. Next one, these are the copper penny bodies, medlar bodies, sclerotic bodies. Remember, C for C, this is seen with chromoblastomycosis. Okay, this is chromoblastomycosis. Is it a subcutaneous wala form mycosis? Is it a subcutaneous mycosis? Just give me a minute, I'll get the charger. Yes, remember in subcutaneous mycosis, you have S and C, that is sporotrichosis and chromoblastomycosis. Out of that, chromoblastomycosis will be given as verrucous lesions and sporotrichosis will be given as ascending nodulo-ulcerative lesions along the lymphatics, right? This is going to show verrucous lesions, okay? What is this one here? Which looks like a candy appearance, जैसे lollipop candy होता है. Candy wala appearance is seen with Candida albicans. What is this called as? Raynaud-Broad phenomenon. Okay, Raynaud-Broad phenomenon or germ tube formation. Raynaud-Broad phenomenon or germ tube formation, that is Candida albicans. This was asked in the last FMGE exam as well. What are you seeing here? There's a fungal, there's a cavity inside which you see this fungal ball, and look at the remaining black air. What is the shape of the air? This is crescent shape. This is air crescent sign, monod sign. Remember monod, moon jaisa crescent. This is seen with fungal ball. Okay. In a cavity, the fungus comes and sit like a patient of TB. Fungal ball, which is aspergilloma. Okay, which is aspergilloma. The aspergilloma is the fungal ball seen in a pre-existing cavity. Right. Going to next one. What is this you are seeing here? Which fungus is this? India ink preparation for the capsule. Encapsulated yeast kaun si hai? Cryptococcus. Okay, remember Cryptococcus is encapsulated yeast. You use here India ink. Okay, and what is the other stain? Mucicarmin. Mucicarmin is the other stain. CC, mucicarmin. So whenever you have a HIV positive patient with the lung infection which is given, remember it is just yes. Yeah. So HIV positive patient with lung infection, it can be Cryptococcus and it can be PCP also. It is not always PCP. Cryptococcus is going to be mucicarmin positive, and PCP you will have Gomori methenamine silver stain positive here. It cannot be cultured. It gives the P for P ping pong ball appearance. Okay, ping pong ball appearance. That is what you have for PCP. Okay, clear with everyone? Right. Going to next one here. What organism do you think here if I tell you that this was post meningitis? Post meningitis, right? So the patient had meningitis, उसके बाद फिर adrenal hemorrhage हुआ, shock हो रहा है, petechiae हो रहे हैं. There are features of shock. This is basically talking about Waterhouse-Friderichsen syndrome. Okay, Waterhouse-Friderichsen syndrome, which is seen with Neisseria meningitidis. Okay, Neisseria meningitidis. And remember that Neisseria infections are common. If a patient has recurrent Neisseria infections, then what pathology do you think about? If there is recurrent Neisseria infections, then what pathology do you think about? Terminal complement deficiency. Okay, remember terminal complement deficiency is what will you think about? C5 to C9 deficiency, MAC deficiency, correct. And if a patient has recurrent staph infections, recurrent staphylococcal infection, recurrent Neisseria में हमने terminal complement देखा. अगर recurrent staphylococcal है, स्टैफी कैट, याद है स्टैफी कौन है? स्टैफी हमारी कैट है. कैट मतलब catalase positive है staph. Recurrent catalase positive infections, these are seen with chronic granulomatous disease. Okay, chronic granulomatous disease where there is respiratory burst, NADPH oxidase deficiency. This is also your recent FMGE exam question. Respiratory burst is NADPH oxidase. Okay, that's CGD. Correct. Next one, what do you see here? Where you see this ऐसे capsule की वजह से ऐसा दिख रहा है. This is McFadyen's reaction. This is the black issue. So remember this McFadyen's reaction. McFadyen, ANAN, is seen with anthrax. Anthrax has a capsule, remember, which is polypeptide capsule, not a polysaccharide capsule. McFadyen's reaction. M for the colonies show medusa head appearance colonies. And this is the black issue, right, which is seen with cutaneous anthrax. Okay, which is seen with cutaneous anthrax, black issue. Cutaneous anthrax is also called as malignant pustule. Okay, it is also called as malignant pustule. Anthrax can be, wool sorters and Hyde Potter's disease. Wool sorters is pulmonary, Hyde wala Potter's is cutaneous anthrax. Okay, so that's going to be anthrax. Correct. Going to next one. What is this here? This is showing the Ryle's tube. जहाँ पे ऐसे वो मेटल बॉल दिख रहे हैं टिप पे, ये राइल्स ट्यूब है. क्वेश्चन आता है कि राइल्स ट्यूब की लेंथ हम कैसे मेजर करते हैं, कहाँ से कहाँ? Tip of the nose to the ear and to the xiphoid process. Remember, this is called as necks. Okay, nose to ear to xiphoid. This is how you measure the कि कितना लेंथ डालना है हमें राइल्स ट्यूब का. ठीक है, so necks is basically the technique to measure the Ryle's tube. Okay, very, very important image. What do you see here in the floor of the mouth? A cystic lesion in the floor of the mouth. This is going to be ranula. Okay, this is going to be ranula. Sublingual gland में जो होता है, right? This is extravasation cyst more than a retention cyst. You do marsupialization. If it goes into submandibular space, you call it plunging ranula. Okay, then you call it plunging ranula. Correct. Now, this is the image I've included because this has been asked in the recent FMGE exam as well, right? So, I hope you have solved the recent questions. And the question was, कि C wave in JVP corresponds to between what 2 points? Is it between point A to B, point B to C, C to D, or D to A? So, what will the C wave in JVP correspond to? Which area here? Yes. What will be the answer? ये है, यहाँ पे लिखा है A, then this is B, this is C, and this is D. Very good. Correct. So that's going to be point A to point B. That is what is going to be the C wave. Now remember in JVP, C for contraction of the ventricle, isovolumetric contraction. जब ventricle का contraction start होता है, मतलब systole start होता है, तब आता है ये C wave. Okay, so C for contraction, isovolumetric contraction, that means the volume is not changing. So here the volume is changing, here the volume is changing. तो ये वाला तो नहीं है, या A to B है या C to D है. In isovolumetric contraction, the pressure increases. So A to B is the point which is telling you this is isovolumetric contraction. If I tell you that what valvular event is occurring at point A, always remember, like in PV loop, take this as the first point and remember the valvular event by the mnemonic COCO-MAM. Okay, you'll never forget this COCO-MAM, which is closure of mitral, opening of aortic, closure of aortic, opening of mitral. Okay, so this is going to be COCO and it is going to be MAM. Okay, this is how it is going to be COCO-MAM. Closure of mitral, opening of aortic, closure of aortic, opening of mitral. Once the mitral valve opens, then the filling of the ventricle occurs. So this is where the volume of the ventricle is increasing because of the filling which is happening. Okay, because of the filling which is happening. Is this clear with everyone? So remember, COCO-MAM is the sequence here. Okay, COCO-MAM. Okay, clear with everyone? Right? Okay. And what will this point correspond to? Point D to point A is going to be what point? Which wave in JVP will the point D to point A correspond to? What wave in JVP will this correspond to? Yes? Here the emptying of the ventricle is happening, right? So remember, emptying of the atrium is happening into the ventricle. Emptying is the Y wave. Okay, remember the Y wave is what you see with the emptying of the atrium into the ventricle. That's the filling of the ventricle. Emptying हो रहा है ना यहाँ पे, emptying हो रहा है. ठीक है? Clear with everyone? So that's going to be the Y. Okay, that's going to be Y. Is this clear with everyone? Right? It's going to be the Y wave. Going to next one. In which condition do you use this and what are these called as? What is this and where do you use this? Of course you are seeing कि ये foot वाले shoes हैं तो कोई foot वाली condition होगी. बच्चे में कौन सी foot वाली condition होती है? That is CTEV. CTEV में ये क्या use करते हैं? Remember C के बाद आता है D. What is the splint name used in CTEV? This is the Dennis-Brown splint. Okay, this is the Dennis-Brown splint which is used in CTEV and CTE. Remember the angle name is kite. Kite angle is what is used in CTEV. Right? Clear with everyone? Dennis-Brown splint. Correct. CTEV. Okay, that is CTEV. Going to next one. What are you seeing here? Pancreatitis में ये signs देख सकते हैं discoloration वाली. ये वाली कौन सी है और ये वाली कौन सी है? Remember the one which you are seeing in the center, periumbilical, C for center, that is the Killen sign. Okay, Killen sign in the center. Flanks में basically जहाँ पे हम turn करते हैं on the side, turning वाले point पे flank में turn, it is called as gray turners. Okay, gray turners is the flank wala. Center wala is the Cullens. So Cullens and gray turners are these specific for pancreatitis? No. They just indicate retroperitoneal hemorrhage that can occur in ectopic pregnancy also. Okay, so Cullens and gray turners. Going to next one. Identify this nerve here. What is this nerve here in the brachial plexus? What is this nerve here? Yes. What nerve is this? Very good. That's the median nerve. Okay, that's the median nerve that you are seeing here. How do you identify the median nerve? Remember, is beach wala nerve. If you write the brachial plexus like this M pattern, okay, try to identify that M pattern. So this nerve, which is getting contribution from both the cords, the lateral and the medial. Remember, beach ka nerve, median nerve gets contribution from both the lateral and the medial cords. Okay, the lateral and the medial cords, that's the median nerve. Okay, और फिर ये M में ये जो lateral cord से आ रही है nerve, फिर ये lateral cord contribute कर रहा है median में, यहाँ पे है medial cord और फिर ये आएगी ulnar nerve. Okay, so what is this nerve here coming from the lateral cord? We had seen initially first session में, ये lateral cord से जो आती है ये है musculocutaneous nerve supplying BBC muscles. हमने पहले session में देखा है, right? And this cord which you see here, this cord here, this is the posterior cord, giving the axillary nerve and the radial nerve. Okay, that is giving the axillary, radial, musculocutaneous. Then you have the median and the ulnar nerve. So remember Marmu, right? हमारे president का नाम याद रखना. Marmu वाला are the 5 terminal branches coming from the brachial plexus. Okay, so you have musculocutaneous, axillary, radial, median and ulnar nerve. Okay, and ulnar nerve. Is this clear with everyone? Right, so axillary and radial come from the posterior cord. Okay, they come from the posterior cord. Ulnar on the median side comes on the medial side, comes from the medial cord. Okay, so these are the 5 terminal branches of brachial plexus. Is this clear with everyone? Right, going to next one. What are you seeing here? कौन सा dehiscence है यहाँ पे? Zenker's diverticulum भी आता है यहाँ से. So basically you will have here Killian's dehiscence जहाँ से Zenker's diverticulum आता है. So the question here is, Killian's dehiscence is the dehiscence in the what muscle? Inferior constrictor. Remember, Killian's dehiscence is the dehiscence in the inferior constrictor, which has 2 parts, right? So you have the thyropharyngeus and the cricopharyngeus. You have the thyroid cartilage, cricoid cartilage. So thyropharyngeus, cricopharyngeus के बीच वाला जो part है, यहाँ पे होगा Killian's dehiscence, जहाँ से आएगा Zenker's diverticulum, which is seen in what age group? Elderly. It is not a congenital diverticulum. Okay, elderly में ये weak होगा, फिर वहाँ से diverticulum आएगा. Classical triad of halitosis, regurgitation and dysphagia is what you get in Zenker's diverticulum. Okay, so remember, this is in the inferior constrictor, thyropharyngeus and cricopharyngeus. Going to next one, this is mammography showing chunky calcification called as popcorn calcification. Popcorn calcification in mammography is seen in fibroadenoma. Okay, it is seen in fibroadenoma. Popcorn calcification in pelvis in a post-menopausal female. Previous FMGE exam question. In pelvis in post-menopausal female. What is it suggestive of? A degenerating fibroid. Fibroid gets calcified. Okay, degenerates. And popcorn calcification in the lung. Even this is your FMGE exam question. Lung में याद रखना hematoma. Pulmonary hematoma. Remember it as hamara tomara popcorn. Hamar tomar popcorn, that is hematoma. Pulmonary hematoma shows popcorn calcification. Okay, clear with everyone? Going to this one, this is not a IVP image, this is an X-ray image showing the staghorn calculi. Okay, these are staghorn calculi on X-ray associated with what infection? Associated with Proteus. Okay, urease positive, Proteus, staghorn calculi is common with this. What is the shape of the crystals that you see here? Right, it is a triple phosphate stone, also called as true white stone, triple phosphate stone. Remember, true white color clothes we wear for funeral, that is coffin lid appearance. Okay, white clothes for funeral, that is coffin lid appearance. Okay, white for funeral, coffin lid appearance. Proteus से ये commonly associated है. Next one, what is this showing? Barium swallow. What is this appearance? This is corkscrew appearance, which is seen with diffuse esophageal spasm. Corkscrew appearance, diffuse esophageal spasm. Next one, important question. How many bubbles are you seeing here? 1 bubble and 2 bubble. So where do you see this double bubble appearance? Where do you see this double bubble? Remember double bubble DD. This is seen in duodenal atresia. Okay, annular pancreas, duodenal atresia show double bubble appearance. Duodenal atresia has bilious vomiting, right? Versus CHPS has what vomiting? Non-bilious vomiting. CHPS will show single bubble. Okay, this is double bubble, duodenal atresia, bilious vomiting. CHPS presents later at 2 to 4 weeks. It does not come immediately after birth. It shows non-bilious vomiting at 2 to 4 weeks. Okay? Yes. Right. So this is double bubble. Your recent FMG exam asked the question on triple bubble. Remember stomach, duodenum, फिर jejunum. So jejunum is what shows triple bubble. When there is jejunal atresia, that is when you would see triple bubble appearance. Okay? Clear with everyone? Right. Yes, duodenostomy is what you do for treatment. Correct. Double bubble के लिए duodenal atresia के लिए DD करेंगे. Duodenostomy. Next one, very favorite image. This is barium swallow showing massively enlarged esophagus with the bird beak appearance niche. This is achalasia cardia. Okay, achalasia cardia where you see mega esophagus. Achalasia cardia, what is the gold standard investigation? Manometry and not 24-hour pH monitoring. 24-hour pH. pH is for acid. So for acid reflux, GERD, you do 24-hour pH. For achalasia, you are going to do manometry. Okay, manometry is for achalasia. Is this clear? Name of the surgery for achalasia, you should know this. Poem surgery. Per oral endoscopic myotomy. Muscle को cut कर दो. Per oral endoscope से जाओ. जो muscle इतना contracted है, right? उसको आप cut कर दो. So poem is surgery done for achalasia, right? Correct. Going to next one, this is barium enema. You can see the barium here, you can see the barium here, and look at the barium here, which is becoming like a claw. So where do you see this claw sign? Claw sign is seen in intersusception. Okay, remember intersusception, claw sign, coil spring sign. It is seen on barium enema. It shows red currant jelly stools. Okay, the history will be of red currant jelly stools. It is intersusception. The first treatment that you do is enema. Air enema, pneumatic reduction is what you give. When it is recurring, third recurrence ke baad, then you go for surgery. Okay, this is intersusception. Claw sign and other sign is coil spring sign. Next one, what is the diagnosis here? First, look at the identification of the structures. Very, very important. Remember in radiology, your right is patient's left and your left is patient's right. Okay, and coming from right to left, the arrangement of the structures is SAP. Remember, SAP comes from right to left. So, सबसे rightmost structure is superior vena cava, then it is ascending aorta, and then it is pulmonary artery. Right, so pulmonary artery normally is to the left of the ascending aorta. Okay, so look at this image here. The dividing one, the branching one here is the pulmonary artery, and you see a filling defect here. Okay, you are not seeing the contrast in this area. What is this suggestive of? This is suggestive of pulmonary embolism. Okay, important image. This is pulmonary embolism. What is the investigation of choice for pulmonary embolism? What is the investigation of choice for pulmonary embolism? It is CT pulmonary angio. Where, how do we give the contrast? We give the contrast IV, not into the pulmonary artery, not into the femoral artery. Okay, we give IV contrast. What is the screening test for pulmonary embolism? The screening test is D-dimer. Okay, D-dimer, if it is increased, then you go for CTPA. And the name of the criteria to look for the probability of pulmonary embolism is Wells criteria. Okay, we have Wells criteria for pulmonary embolism. Okay, it's Wells criteria. Clear with everyone? Right? Going to next, what is this structure here? This is pulmonary artery. What is this structure adjacent to pulmonary artery? Aorta. What has happened to the aorta? There is bifurcation, dissection which has happened. So this is aortic dissection. Okay, aortic dissection. What classification? Stanford classification. This is what aortic dissection, Stanford A or B? This is Stanford A. Remember, because it is involving ascending aorta. A involved, it is Stanford A. And remember, it's an acute condition, emergency. You need to do surgery if it is Stanford A. If it is Stanford B, below the ascending aorta, then you can give beta blocker if the patient is stable. But if the patient is unstable, then you will go for ascending aorta wala, also yeah, B wala, you will go for surgery. Okay, this is Stanford A. And remember, in aortic dissection, they generally give you history of hypertensive patient with acute chest pain like MI. It goes to the back, and there can be unequal pulses in the upper limb as well. Okay, right and left upper limb में pulses, blood pressure unequal हो सकता है, blood pressure pulse unequal हो सकता है in the upper limb itself. Okay, this is aortic dissection. Is this clear with everyone? Going to next one, look at this. What is this image showing here? Look at this image very carefully. What are you seeing? There is this white collapsed lung, and surrounding that, this entire black thing is the pneumothorax. Remember, air is black on X-ray and CT. Okay, so this is the surrounding one, is the entire black one here is the pneumothorax, and this one here is the white collapsed lung. So what is the diagnosis here? Pneumothorax. How do you identify tension pneumothorax? When there is shock present, right? Hypotension, shock present. It's a tension pneumothorax. And when it's a tension pneumothorax, then you do needle puncture. Okay, then you do needle puncture in that case. Clear with everyone? Right? So first thing is needle puncture in tension pneumothorax. And after that, you put a ICD for the remaining air. Where do you put the needle? In the adults. A for adults, axillary line, 5th intercostal space. C for children, C for clavicular line, 2nd intercostal space. Children may 2nd, adults may 5th. Children may clavicular, adults may axillary line. Okay, is this clear with everyone? Right. And what is this one here? White color is not the air. White is the fluid here. And look at this meniscus curve jaisa. This is classical of pleural effusion. Okay, this is classical of pleural effusion, Ellis curve. Okay, this is called as Ellis curve that you are seeing here. Okay, in pleural effusion, there's going to be dull note on percussion. In pneumothorax, there's going to be resonant note on percussion. Okay, that's the difference in between the two. Okay, going to next one here. What are you seeing here? Air beneath the diaphragm. This is pneumoperitoneum. Okay, this is pneumoperitoneum, air beneath the diaphragm, which is because of hollow viscous perforation. Generally, the history they give you in the question is a patient of peptic ulcer disease. So, the ulcer is perforating and leading to pneumoperitoneum. There's going to be guarding rigidity that's going to be present. And pneumoperitoneum, air beneath diaphragm, you need to do exploratory laparotomy. Surgery needs to be done here, right? Exploratory laparotomy. First is IV fluids, resuscitation, IV fluids दो और फिर उसके बाद surgery करो. Okay, pneumoperitoneum. Going to next one here. This is a CD scan with the white bone. And what is this white in the CT? Two things which are white on CT that you should remember. One is calcification and other is acute hemorrhage. Okay, calcification and acute hemorrhage. So remember, this is acute hemorrhage here. Okay, this is acute hemorrhage here, this which you are seeing, acute intraparenchymal hemorrhage, the most common cause of which is hypertension. Okay, the Bouchard's aneurysms, lenticulostriate arteries which rupture, and that is why the most common site is also basal ganglia. The most common site, basal ganglia, putamen is a very common site. This is not subarachnoid hemorrhage. Subarachnoid hemorrhage is going to be in the CSF containing spaces. Any acute hemorrhage basically is white. Okay, clear with everyone? Okay, going to the next one. What are you seeing here? Again, another hemorrhage, but look at the shape of the hemorrhage here. It's a biconvex shape. Biconvex, EX, it's an extradural hemorrhage, which is biconvex shape. Okay, biconvex extradural hemorrhage, which is because of rupture of middle meningeal artery. It does not cross the sutures. Okay, this is extradural hemorrhage, which is biconvex, acute. Right side or left side? This is your left side, but patient's right side. Okay, so this is right acute extradural hemorrhage. Going to next one, in which condition do you see this sign here? The sign which is shown here, this is the black air in the colon, and suddenly this air is cut off here. You do not see the air beyond this point. So this is colon cutoff sign. Again has been asked in one of the recent exam. Colon cutoff sign is seen in acute pancreatitis. Okay, colon cutoff sign is seen in acute pancreatitis. What is the investigation of choice? CECT, contrast enhanced CT. What is the finding that you see in CT with acute pancreatitis? Any organ which is acutely inflamed becomes enlarged in size. Edematous, bulky. So that is what is given in the question. Remember, bulky pancreas is suggestive of acute pancreatitis. What enzymes are increased here? Amylase and lipase. Lipase is more specific. Generally, the history they give you here is an alcoholic patient. Okay, alcoholic patient, epigastric pain हो रहा है. Okay, and it's amylase lipase increase. CECT is what you do here. You have CT severity index. CTSI score is for acute pancreatitis. Right. Next one here, if you look at this image, this was asked in the recent NEET PG exam as well. There is some white calcification that you see in the pancreas location. So if you see this white pancreas, calcification is present. Remember, calcification, C for C, it is chronic pancreatitis. Okay, this chronic pancreatitis, when you see calcification in the pancreas like this, chronic. Dr. Phoenix, Alvarado score, remember A for appendicitis. Okay, acute appendicitis, you have Alvarado scoring. You have bicep, Ranson's, that is what is used for acute pancreatitis. This is chronic pancreatitis, and remember the other C for chronic pancreatitis, chain of Lake's appearance. Okay, chain of Lake's appearance is what you see here. Next one, coming to few last images here, classical image, copper ring wala. This is the KF ring, all right. This is seen in Wilson's disease. What kind of cataract do you see in Wilson's disease? What kind of cataract do you see with Wilson? Remember, Wilson is sun, that is sunflower cataract. Okay, sunflower cataract is what you see with Wilson's. Increased urinary copper, decreased serum cellular plasmin levels, increased copper in the liver, ATP7B gene, right? Okay. Okay. And what are you seeing here? In which condition do you see these spots in the iris that you are seeing here? What are these? What are you seeing here in the iris? Very good. Correct, Nirday, that these are the brown colored nodules here. These are called as Lisch nodules. Right? Remember, these are Lisch nodules seen with NF1, where you have caffeolae, neurofibromas, optic glioma. You have the Lisch nodules here. This is NF1. What condition is this one here? What are you seeing here? The port wine stain is permanent stain. Encephalotrigeminal area में दिखता है face में. So you have this port wine stain. Okay, port wine stain with seizures. That is the classical history given in Sturge-Weber syndrome. Remember, Sturge-Weber S has seizures, has stain, and another S is, it is a sporadic condition. Okay, it's sporadic. It might come suddenly without any family history. Okay, it is sporadic. Encephalotrigeminal angiomatosis is what you have here. Correct, right? There can also be glaucoma which can come in here, which is given in the question. Okay, right. In the brain, it gives the tram track calcification. Tram track calcification in the brain is seen in Sturge-Weber syndrome. Next one here, what are you seeing here? CT scan mein, this is the kidney, the left kidney, the right kidney. Look at the right kidney. The right kidney is showing some lesion which has this dirty black appearance. It is not jet black but dirty black, that is fat. Remember, fat has a negative HU value. Fat containing lesion in the kidney, this is angiomyolipoma. Remember, when there are bilateral angiomyolipomas, you think of what condition? Tuberous sclerosis. Okay, you think of tuberous sclerosis, angiomyolipoma. Okay, tuberous sclerosis. And dirty black appearance with some vessels also that you can see. This is angiomyolipoma. Okay. देखो, Dr. Finn, it's easy to understand. If it's a cyst, it's going to be water is gray color on CD. Fat is dirty black appearance. If it's a renal cell carcinoma, it's a solid tumor. It will be more white and more enhancing. It's going to be solid tumor. This is dirty black appearance, angiomyolipoma. Okay. Right, I believe so. This was the last slide that we had. And yeah, tuberous sclerosis, tuberin, hamartin. You have chromosome 9, chromosome 16. It's autosomal dominant, right? You have ash leaf macules. You have adenoma sebaceum, Sjagren's patch. All of that is seen in tuberous sclerosis. Okay. Yes. So that was about the final punch Sureshot session 3, where we have just tried to have a glimpse of the most important topics, right? Anybody who's on Radsynapse up, guys, last में Sureshot बहुत अच्छे से revise कर लेना. Quickly go through the PYQs, question answer, and whatever areas you think ये मुझे याद नहीं रह रहा है, that is something that you keep for your last minute revision. PDF, blank PDF has already been shared on the Telegram group. I'll share the annotated PDF also on the Telegram group. Okay. Done. हेमंग, एटलीस्ट इतना याद रखना कि हर पीस में हमें पार्टनर ट्रीटमेंट नहीं देना होता है. ठीक है. Creating happiness, if you can share your doubt, exactly what is a doubt कि urethral rupture में क्या समझ में नहीं आ रहा है, then I'll be able to help you. Okay. Right. When are we meeting again next? We are meeting again next at 7:30 p.m. Right, with few more important, the last minute revision points that you should definitely revise based on your PYQs and, the potential questions that can come in the exam. Okay. Sanjeev, urea cycle, Krebs cycle again has been discussed in the Radsynapse app. If you want, you can check out there. And how to overcome anxiety, right? Just try to detach yourself from the results of the exam and your anxiety will be gone, right? You become anxious, when you expect a lot of things and, especially when the things are not in your control and you're trying to control them, right? How the exam is going to be, what kind of questions are going to come, result kaisa hoga, hamara performance kaise hoga, right? So just go with the flow, right? Make the best use of the limited time that you have and detach yourself from the result. Just focus on giving your best attempt, right? So focus on the controllables and not on the non-controllables. That is what is going to help you decrease your anxiety. And like I said, practice Yog Nidra. Okay, that really helps. Oh wow, Saurabh is here. Okay. हाँ देखो, वो लास्ट डेज में ऐसे ही होता है, क्या पढ़ना है क्या नहीं पढ़ना है समझ में नहीं आएगा. वॉट एवर मेहनत यू हैव डन इन द लास्ट 6 months और सो, दैट इज वॉट इज गोइंग टू हेल्प यू इन योर एग्जाम, right? So in the last days only focus on things that you are not able to remember. Okay, जो याद है उसको बार बार रिवाइज मत करो. No, ठीक है. ध्वनि, वाइबिलिटी, मायोकार्डियल वाइबिलिटी के लिए पेट स्कैन है, फंक्शन के लिए मूगा स्कैन है, इस्केमिया के लिए थैलियम स्कैन है. ओके, दैट्स व्हाट वी डू. हाँ देखो, in the remaining time, again like I told you, from 8th of January only divide into 5 subjects और उस पे फोकस करते जाओ. अगर वो नहीं किया है तो अभी सिर्फ try to give just 2 hours 3 hours each subject and try to do only the go retrospective if you want to, कि PYQ solve कर रहे हैं और quickly फिर note down कर रहे हैं कि these are the topics which I was not remembering and you revise only those. You cannot revise everything in these last 2 days, so don't go behind that. Yes, Saurabh, thank you so much for acknowledging that. So yes, absolutely, the short sessions that we are conducting on YouTube as well for the students who are not on Radsynapse app. Please revise this. You'll see a lot of questions in your exam based on this. Okay. All right. I'll see you again at 7:30 p.m. guys for the final short session where we'll try to cover a lot of maybe one-liners, the PYQs in the form of one-liners, right? And that is going to be the last academic session. We'll meet again tomorrow for the exam hall strategy, right? Thank you so much, everyone. Have a great day and goodbye. Take care and keep studying, keep revising, keep synapsing, and keep winning. Thank you.